Again, I would like to thank the organizers for giving me the opportunity to visit Delhi. I always love Delhi in the winter months, coming from Chennai, where I think the lowest temperature touches about 22 or something in the nights of peak winters. This is something which we see in our daily practice. Organisms lurking around, which very often colonize the patient, as we have seen from Dr. Kilnani's talk. A study was done by Marin Koloff about 5 years ago, where he checked the clinical characteristics and treatment patterns among patients with VAP in several ICUs. And to cut a long story short, he found that more than 100 different antibiotic regimens were prescribed for initial treatment of VAP. The overall mortality was about 25%. And he concluded saying that the treatment patterns for VAP vary widely from institute to institute, and the overall mortality rate remained very high. The de-escalation of therapy in VAP patients appears to be associated with a reduction in mortality, which is an association that warrants further clinical study. So, when we talk about antibiotic usage in the treatment of VAP, we have to balance it between the appropriate initial antibiotic treatment versus avoiding unnecessary use of antibiotics, which engenders resistance. So what do we know about current practices? We know that the use of inappropriate antimicrobial therapy among intensive care physicians is reasonably high. This study is from the US. If you look at community onset infections, the incidence is about 17%. If you look at hospital acquired infection, it is 34%. But the use of inappropriate antibiotics was as high as 45% in patients who came in with a community-acquired infection and then went on to develop a VAP. We also know that inappropriate antimicrobial therapy increases mortality. This was a landmark study which showed that if appropriate therapy led to a mortality of 17%, inappropriate therapy led to a mortality as high as 42%. And this was subsequently confirmed by several studies, all of which demonstrated that the initial adequate antibiotic therapy made a significant impact on the mortality of patients. So if you get your initial antibiotics wrong, you are in deep trouble. What more? It was also shown that not only do you have to get it right, you also have to time it right. Every hour delay, these are patients not of VAP but of sepsis, but every hour delay in the initiation of antibiotics severely caused an increased mortality. And to make it more complicated, not only do you have to get it right and time it right, if after initial cultures are sent off, the patient is assessed 48 to 72 hours later, and you get the reports, you de-escalate to a narrow spectrum antibiotic, the mortality was only 17%, whereas you continue the same antibiotic, which a lot of us tend to do because the patient is doing well, we say, okay, let's continue with meropenem even though it is sensitive to ceftriaxone, the mortality was 23%. But if you escalated, in other words, if you had got the initial choice of therapy wrong and it turned out to be a resistant organism and you went on to give the appropriate therapy, the mortality was high as 42.6%. So having seen all that, what is the right approach in handling patients? Now this is a simplified algorithm, which when you suspect VAP or HAP, the first is to obtain a lower respiratory tract sample. I won't go into the details. Dr. Kilnani has mentioned tracheal aspirate is reasonably accurate and a bronchoscopic specimen is good enough. You don't need to do pneumonia or a negative microscopy, in which case you don't need to do anything. Otherwise, you need to start empiric therapy. But what is more important is you need to assess the patient. Do you have another pointer? This doesn't seem to. The most important aspect is to assess the patient after 48 to 72 hours, so that if, depending on what the cultures show, you can either de-escalate, stop therapy, or depending on what resistance you find, you may even sometimes have to escalate if you have got it wrong in the first place. So how do you initiate the antibiotic therapy? Choosing the appropriate antibiotic therapy depends on the local antibiogram. It doesn't work if I follow the ATS recommendations to treat VAP in Indian context. I need to have a local antibiogram. 2 years ago, if my patient in the Apollo ICU developed a VAP, I would probably start him on a carbapenem. But now, for the last 6 months, if a patient develops a VAP, especially a late onset VAP, I know it is most likely to be an Acinetobacter, so I need to cover it with carbapenem's resistance as high as 80%. I need to use either colistin or another suitable antibiotic. Irizarry showed that if there was a delay in the appropriate therapy for patients with VAP, the mortality can be as high as 70%, whereas if you started within the first couple of hours, your mortality can be as low as 30%. And similarly, Alvarez also showed that if you modify therapy, unfortunately you get a resistant bug and you modify therapy subsequently after 2 or 3 days, the mortality was about 25% compared to a decreased mortality of only 16 if you got it right. In the event that the person has received prior antibiotic therapy, you need to choose an antibiotic class which is different from the original. So if the patient has already received a cephalosporin, a carbapenem would be appropriate. Or if the patient has received a carbapenem, then you may have to resort to a BL-BLI based regimen or a colistin or a polymyxin based therapy. We also need to keep in mind when we choose the antibiotic, underlying disease. Does the patient have chronic obstructive airway disease? Is he an alcoholic? Has he been exposed to hospital before? Features which can suggest resistant bacteria. Predictive value of respiratory cultures has already been discussed, but what I just want to highlight is that even if you have a pre-existing swab from the patient, it is very important that it is a recent swab. The study, very nicely done by Dr. Khilani, showed that with time the colonization varies. So if you have an ET secretion done 5 or 6 days before, it may not truly reflect what is happening. So you need to have a reasonably recent sampling to choose your antibiotic right. The concept of early versus late VAP is said that if the person develops VAP within 4 days of admission to hospital versus more than 4 days later, the chances that this could be due to a resistant bug, whereas this could be due to a community-acquired pathogen like strep pneumonia, is no longer valid because most tertiary care centers where we work are having patients who are usually treated elsewhere. So by the time they come in, they are usually referred from an outside hospital, maybe already ventilated or have spent some time there. So the strict distinction whereby we say that the late VAP is associated with the resistant organism no longer is true. There was concern about lung penetration of antibiotics. Studies show that antibiotics like macrolides and linezolid, which reached good concentration in the alveolar macrophages or the bronchial lining fluid, probably would be superior to drugs like, for example, vancomycin if you are comparing treatment of MRSA. But again, studies reveal that this may not be always true. If you choose the correct concentration of the drug or the dose of the drug, for example, if you use vancomycin and make sure that you keep the trough levels about 15 to 20, then it is probably as effective as using linezolid. You need to have a protocol in place, and this protocol should be institutional based. So what I use in South may not be applicable for what you have here. And most importantly, we should keep in mind the risk of resistance in our scenario. So what are the factors which make you suspect that the patient could be colonized by a resistant pathogen? If the current hospitalization is more than 5 days, this could be in our hospital or elsewhere also. Any recent preceding 3 months history of antibiotic therapy, recent hospitalization, high frequency of antibiotic resistance in the community, which probably all hospitals in India would come under, residence in a nursing home, home infusion therapy, dialysis, home wound care, family member with a multi-drug resistant pathogen or immunosuppressant use. So in this situation, probably you may need to use a broader spectrum antibiotic to tackle the problem. It is not enough if you get it right. You need to make sure that you give it right. So of course, all of us use intravenous therapy, but there is a lot of evidence recently about optimizing PK/PD. We know that beta-lactams and carbapenems act by a time-dependent fashion, and the aminoglycosides act by a concentration-dependent fashion. So do quinolones. So when you use beta-lactams, there is more and more stress to ensure that you give a prolonged infusion. This is to ensure that you keep the drug levels above MICs consistently. So either you need to give a continuous infusion or at least an extended infusion. But there are caveats to the use because the stability, it is very, very worrying that in ambient temperatures in most ICUs in India, which could be in the region of anywhere from 25 to 35, the stability of the drugs which are going in an extended infusion has to be kept in mind. What do you use to dilute the constituent? For example, it has been shown that 5% dextrose can actually be detrimental to the stability of the drug. Normal saline is preferable. If you're using drugs like carbapenem, for example, extended infusion of meropenem over 3 hours is probably superior to using it as a half an hour infusion, which is what is currently recommended by the company. If you are using piperacillin and tazobactam, a 3-hour infusion 4 times a day is more effective, especially when you are dealing with resistant organisms which have a higher MIC. But please remember, when you give a maintenance, you ensure that a bolus is given, especially for beta-lactams, because when you start with the extended infusion, it takes time to reach the peak levels. So you need to give a bolus before you do it. Is there any role for local instillation? local instillation alone probably may not have any benefit, but again with resistant organisms, Acinetobacter, where your options are limited, adjuvant nebulized antibiotics can help. But again, you have to remember that the way it is given, the nebulization, the method, the nebulizer used, the way in which it is given play a very important role in local instillation. What about combination therapy? A lot of us feel combination therapy is superior. Yeah, before we go to combination therapy, this graph says the drugs which act by concentration dependent fashion have a post-antibiotic effect, so that even if the level goes below the MICs, they are still effective. Whereas for drugs which act by time dependent fashion, rather than giving it, they may need to be given more frequently or as a prolonged infusion to keep it above MIC. But make sure that to get it there, you need to give a bolus. Recent studies show that vancomycin as an extended or a continuous infusion has very good effect, and similarly, colistin also is being considered. If you use combination therapy, we feel that the coverage could be better. It can decrease the length of stay. It can probably prevent resistance developing and also decrease the chances, improve the handling of resistant bugs. But all these have been proven to be false. It's only improved coverage which probably makes a difference when you use combination therapy. And the large meta-analysis which came out about 2 or 3 years ago showed that there was no evidence that combination therapy improves survival when compared with monotherapy. And there is no evidence that combination therapy results in lower rates of treatment failure. So the false opinion that when you combine drugs, synergistically they act better is probably not founded in truth. Any other issues? Ensure that de-escalation is done irrespective of whether the patient is doing well with your broad spectrum antibiotic. If you get a narrow spectrum, de-escalate. Keep in mind the role of biofilm when dealing with VAP. It is very important that the organisms go into a phase of less multiplication, whereby they are no longer effective against antibiotics. And that is why the non-inflammatory effects of macrolides seem to help. Using clarithromycin, a study showed that you can decrease the resolution of, hasten the resolution of VAP from 16 days to 10 days. Or if you're using clarithromycin in patients with VAP, you can make sure that they come off the ventilator much faster, 15 days versus 22 days, just because of the anti-inflammatory role of macrolides, which was combined to the regular antibiotic therapy which the patient was given. For specific pathogens, again, earlier linezolid was considered to be superior, but now studies have shown that if you give the appropriate dose of vancomycin, it is equally effective. And in fact, the study showed that linezolid may be associated with a higher risk of side effects due to pancytopenia, which is seen. And if it is gram negative, you need to ensure that the MICs are available. You need to ensure that your microbiology gives the MICs for resistant pathogens. For example, if it is Acinetobacter, the current recommendation for colistin dose is much higher than before. 6 million units as a loading dose, followed by 2 to 3 million units every 8 hourly. Subtherapeutic doses of colistin may actually lead to increased resistance, because there is always a hetero-resistance seen, where a mixture of resistant and sensitive organisms may initially give the picture of a sensitive bug early. Duration of antibiotics. Shastra gave a study in 2003 which he proved that giving antibiotics for 8 days was as effective as giving it for 15 days. This was later confirmed for several reasons. One, it works as well. Two, it showed that the more antibiotics to use, for the example, ciprofloxacin usage, which is in dark dots, when it increased, there was a subsequent increase in ciprofloxacin resistance, and not only that, there was an increased resistance in other gram-negative pathogens also which was seen. So the longer the duration of antibiotics, you engender resistance, and when you use a drug, it is a matter of time before colonization due to other organisms were seen. I apologize for the small one, but the other organisms were Staphylococcus and Enterobacter when ciprofloxacin was used. So when you use prolonged course of antibiotics, it doesn't help. 8 days is good enough. And subsequently, you also cause increased resistance and colonization by organisms which otherwise would not respond to the initial antibiotic. I'm going to leave you with these words, which say the clinical experience has been defined as making the same mistake with increasing confidence for an impressive number of years, in contrast to evidence-based medicine, which involves perpetuating other people's mistakes instead of your own. And this could be quite true. This is a very recent article which has come in the Lancet Infectious Diseases, which was accessed last month, where they did a study to find implementation of guidelines for the management of possible multi-drug resistant pneumonia in the intensive care. It was a multi-centric observational industry-sponsored study where the results were quite startling. Of the 303 patients at risk for MDR pneumonia who were treated empirically and prescribed treatment, and the prescribed treatment where guidelines were followed, that is, if they were compliant with the guidelines, which happened in 129 patients, the mortality was 34%, whereas the mortality was only 20% when the guidelines compliance was not there. In other words, when you follow evidence-based guidelines, it actually led to a higher mortality. The median length of stay and duration of mechanical ventilation did not differ between the two. So the conclusion was, because adherence with empiric treatment was associated with increased mortality, we recommend a randomized trial to be done before implementation of guidelines. There were differences between the two populations. People who are subject to guidelines were more sick, they had Apache score and probably had higher infections with Pseudomonas. But in spite of these variables, there were other independent factors which increased the mortality. So it is high time to consider whether we are doing the right thing by following guidelines. So I would leave you with what George Bush said, that if we don't succeed, we run the risk of failure, which cannot be more true for VAP. Thank you.